Thank you, Marty. It's nice to have all of you here, and I'm really excited to see so many here. I want to give a special acknowledgement to Allison Sundberg, who really put all of this together, got us together, and created this forum for us. So, are you pumped? Well, I am. I've got my Innovation Forum app right here. The scientific sessions are beginning. We are in Chicago. I mean, where else can you hear blues in the washroom but in Chicago? And we are here at the second Heart Innovation Forum, and here's the really good thing. It's about heart failure. So we're delighted to take on this challenge. I want to, in a moment, introduce the panel members. And as Alif told me just a moment ago, she said that both the panel and the audience have been structurally and socially engineered to contribute to a great outcome. And my prediction is that really today will be one of the most impactful days for heart failure that we have all been involved in for a long time. So let me first introduce Dr. Alif Oker. Alif is the Medical Director for Clinical Strategy and Innovation for Blue Cross and Blue Shield of Illinois. Alif, welcome. Dr. Angelina Irizarry Policarpio, and Angie is the Executive Director for Health Economics and Outcomes, Research and Informatics, and Field Teams for Boehringer Ingelheim. Angie, welcome. Dr. Robin Trupp. Robin is an assistant adjunct clinical professor at the University of Illinois College of Nursing, but Robin has worn so many hats in the heart failure field and space, including being the founding member of the American Association of Heart Failure Nurses. David Moore is here with us. David is the director for Northwestern University Center for Behavioral Intervention Technologies. And finally, Amy Cueva. Amy is the founder and the Chief Experience Officer, the Health Principal for HX Refactored Design, Chair at MadPow. And you'll tell us what all that is. In a moment, I'm going to ask each of them to tell us a little bit more about what their work and their passion is, and then from their own personal experience, what they view as the barriers or the obstacles for heart failure, as well as the solutions. We're gonna get to that. You know, Bill Abraham framed so much the problem of heart failure, but I want to give you my own personal frame to this today. 1986, I was a young heart failure and transplant doctor. I was sure I was going to cure the problem of heart failure. The statistics, Bill, were not very different than what you showed today. And then going forward those 30 years, as Bill mentioned, numerous drug device trials, multiple journals, multiple societies focused on heart failure. We have done all those things, and still we have this epidemic. And that's really our challenge. And it's a difficult problem. The patients with heart failure are very complicated, but the one thing, at least I know from personal experience, is that to solve those problems, it has always taken collaboration, teamwork, and innovation. So with that, let's begin, and we're going to start with Alif. Alif, tell us a little bit more about what you do and what you see are some of the barriers.
Thank you. Welcome, everyone, and thank you for listening. I'm Alif Oker. I'm a medical director at Blue Cross Blue Shield of Illinois. Before that, I was an emergency physician and had an academic career for about 10 years. I'm actually a true blue Wolverine, so I've adopted Chicago as my home. Currently, I do a couple of things at Blue Cross. One, I support our municipal business as medical director, so a lot of population health for municipal accounts, for folks who have jobs that involve unions and hourly wages, and the folks who bear the brunt of the disease burden in our culture and in our society. The second hat I wear is I support our social media team as their medical director, and I consult with our mobile solutions team. I also mentor startups. And so to answer your question as to what my passion is getting people in a room who otherwise wouldn't be in a room. Because I think pushing the edge in healthcare requires it. It requires folks who normally don't talk to one another to talk to one another and sort out ideas, because up until now we haven't done that very well.
Okay, great. Thank you very much. Angie, how about you?
Sure. Thank you. I'm Angie Policarpio, and I'm the Executive Director for Health Economics Outcomes Research and Informatics field teams at Boehringer Ingelheim Pharmaceuticals. And they do try to hire people that have complicated names to match the complicated name of the company. But my Health Economics Outcomes Research field teams support various therapeutic areas that would be cardiovascular, respiratory, diabetes, oncology, and IPF. And the informatics teams support both cardiovascular and respiratory. Prior to that, I'm now based out of Connecticut, but prior to that, I've always lived in Chicago, so I just moved to Connecticut in February. And I like to look at my background as in thirds. So I was on the clinical side, did the cardiovascular step down in ER as well. And then I went into the health plan. So I was with Prudential Healthcare before they came out of the healthcare industry, and worked at Blue Cross before Alif came there. And so I spent some time at Blue Cross doing the population health management as well, and building that whole area. So in terms of my passion, I think, like Alif, I share the same passion, having been a clinician and now having the experience of being in the different channels, if you will. There's one common thread that I do see, and that's the collaboration could be better, so that at the end of the day, what it's really all about is better outcomes for our patients, right? And we can only do that if we're talking to one another. So that's one of my passions.
Okay, great. Thank you very much, Angie. By the way, after the panel has said a few words, we're going to really open it up. We need this to be interactive, so please jot down your thoughts or your comments and have some questions. The other thing I'll tell you is we talked several times before while we put this panel together, and I asked them to be bold, to be TED-like, to throw down challenges as well as solutions. So really get prepared for that. The other thing that I think is important to say at the outset is we talked that we're going to focus on heart failure, but really for most of us, heart failure is really a paradigm for all of chronic disease in the country. So agreed?
Agreed.
Okay, all right. I'd like to introduce Robin Trupp, and Robin, tell us about some of the many things that you have done and what your passions are and what you see as the barriers for heart failure.
I'm happy to. Thank you, Mark. Well, good morning, everyone. I have been a heart failure nurse, I guess, about 15 years. I'm an acute care nurse practitioner who got bitten by the heart failure bug early on. I came from a critical care environment where I treated them with electricity and drugs and get them in, move them out, give them Lasix, oxygen, and send them on their way. And so when I entered the outpatient world, it was quite a different environment because patients don't get better with the stroke of a drug or some juice with electricity. It takes a little bit of time, and they need a cheerleader, and they need support, and the family needs encouragement, and because heart failure affects everyone, not just the patient. So I'm here as a voice for the nurses that can be found essentially anywhere and everywhere that there's a heart failure patient. And nurses do contribute and are valuable team members to the care and management of heart failure. So as Mark said earlier, I'm one of the founding members of the American Association of Heart Failure Nurses. I'm also president number 2. I didn't try hard enough, I guess, to be president number 1. But my passion really are those patients with heart failure, their families, and the nurses that provide the non-ending care for them.
Great, thank you. And David, tell us more about what you do and what you see as the barriers from your perspectives.
Yeah, and thank you very much for inviting me. So I will confess here that I am not a heart failure specialist. I'm a psychologist by training, and my area of research and work is really in the interface between technology and behavior. Most of my work is in depression, but the center, let me just tell you a moment about the center that I direct. So the center is focused on trying to use new technologies, or maybe not so new, the web, mobile phones, sensors, and so on, to focus on trying to support behavior change in the service of health, mental health, and wellness. And beyond my own work, the center supports now about 50 projects, around 28 NIH grants, PCORI, DoD, a few grants from Canada, and really focused on a very broad spectrum of clinical targets. So not just my work, but what unifies us really is this interest in trying to harness emerging technologies. And so, just kind of a brief overview, you probably are all familiar with what apps look like. They have a number of different kinds of features. They can provide information. They're tools for feedback loops. Patients can enter data, it gets processed, and then presented to them again in another way that supposedly is motivating and trying to get them to do the things that we want them to do, and they can provide notifications, sort of reminders in the real time. And the challenge, I think, is that what we've learned about apps, when we see, there are maybe 40,000 health apps out there on various app stores, and what we see when with those apps is that around 85% of them are downloaded and never opened. Of those that are downloaded, the vast majority are opened once or twice and never opened again. So about 2.5% end up getting used more than 10 times. And for example, data from a diet app showed that the people who downloaded it and were using it were people who were already engaged in diet. They are people who are vegans or vegetarians, or training for a marathon, or maybe they're involved in some sort of diet. But we're not changing patient behavior with those applications. And so there's a couple of things where I think we can really make progress on this. First is, I think these kinds of technologies need to be embedded in systems. They get used when there's a human face. So they can, you can use coaching or, sort of, low-level staff to kind of support. And when patients know that there's a human behind it, they're more likely to use it. You can integrate it into care, so we're looking at some of the applications we're doing to integrate it into primary care. Just the patients knowing that those data are going to be represented to their physicians increases their use. So understanding kind of how to integrate these into systems so that they're used is one challenge. The other area that I think but that's sort of motivation, and those of us who are clinicians and see patients, most of what we do, I think, regardless of your specialty, is probably motivating people, trying to get them to do the things that we think they should do. Engineers take a different perspective. Engineers try to make things simpler. If there's a problem, they try to make it easier. With the engineers that we work with, one of the approaches, and computer scientists, one of the areas that I think is really exciting is the use of sensor data. And you can think about sensor data in two ways. One is coming from external devices like your Fitbit, or scales that can be Bluetoothed into a phone and the data transmitted and so on. And those can be very useful. But again, as soon as you ask patients to do something that is outside of their regular life, you're going to get a large number who just don't do it. People don't take a pill if you give it to them. So are they going to strap on a sensor for you? Maybe, maybe not. But they do take their phones with them. All of you probably have your phone with you. You would feel sort of naked without it if you left your home without the phone. And in the phone today, there is a growing complement of sensors that can be harnessed. So we've developed software that can pull all of that data into our servers. And one of the things that we're doing right now is trying to develop algorithms that can make sense of all of that data, turn those data into information that's actionable. So for example, if we want to understand sleep patterns, when people go to bed and when they wake up, without asking them to do anything different, we're learning that certain sensors can be paired to start to understand that. So when people go to bed, they usually, the light goes out. There's no sound. Some people plug in their phone or put it in a different mode. And when they wake up, there's sound, there's light. And so pairing these sensors, we can begin to get a picture of people's lives. And this I think, is going to open up a number of opportunities. So one opportunity, is being able to monitor patients at risk. In my area of mental health, we have work going on looking at circadian rhythm as a marker for when people are going to have bipolar patients are going to have a manic attack. We've been able to separate out depressed from non-depressed patients. And there may be a lot of things like that you can do, in heart failure. Another is just-in-time interventions. If we can detect things that are sort of positive, we can begin to reinforce those behaviors in real time so that people have a coach in their pocket that is kind of positively reinforcing the behaviors that we want to see. Or we can offer suggestions when we don't see those. We can stream those data also back to clinicians through a clinician interface so that they can see what the status of their patients. And then the third area I think that's really has not been explored yet, but I think that is potentially huge, is this gives us a window into people's behaviors and their environment, and we can begin to link those in epidemiological studies to begin to pair that data with clinical databases, with genomics databases, and really begin to look at gene environment and gene behavior interaction. So I think that this is one area where I think there are huge opportunities. I would say if you guys there's anybody out there that's interested, I would be delighted to talk with you.
Great. David, thank you very much. So perfect setup. You talked about technology. Bill certainly talked about technology. And Amy, we didn't have you last for no reason. Amy's company really deals with the human factor and how we get human beings to interact and actually enjoy technology. So tell us a little bit about MadPow and your passions and what do you think some of the barriers are and some of the solutions?
Absolutely. So, hello everyone. MadPow is an experience design agency, and the majority of the work we do is in health, though we work in other industries. In health, we are working with companies from across the spectrum, payer, provider, government, nonprofit, health tech, large and small, as well as pharma. And there are many shared objectives amongst those organizations in terms of improving people's health. Our mission is to improve the experiences that people have with organizations, technology, and each other. And we do that through leveraging a human-centered design process that says basically, involve the people who will be affected by the solutions you create in the process of creating them. And it sounds like common sense, but oftentimes patients and clinicians are locked out of the innovation process because we don't have any time, and we're too smart. We don't need them. Actually, they have a lot of interesting things to say. If we want our solutions to work in the context of people's real lives, where they might be dealing with a death or a divorce, children who are giving them a hard time, a layoff, they might not be obedient, adherent, compliant. That's why I like the mental health angle that you bring to the table, David, and the empathy angle that you bring to the table, Robin. I'm passionate about leveraging emotion in design. I think emotion is hugely important in terms of the solutions we create, as well as empathy. I think in industry we can become desensitized and jaded. We've been banging our head against the same wall for so long, we stop feeling it. But I think that empathy can engage us, inspire us, motivate us to envision a better future and to be collaborative in our mission to get there. And how I got into congestive heart failure was through a research project we did with the recently diagnosed, actually for a pharmacy. And in speaking with a patient who I'll call Jim, I immediately felt for him. He was in a time of need, life-changing diagnosis. Change is difficult for people and for organizations, and to tell someone, you have to change your life, you have to get into these new habits, you have to exercise more, you have to completely change your diet, and then send somebody out of a visit with no one to talk to, Googling, calling loved ones, not remembering the information that was just given to them because their mind is racing. Important moment of transition, and made me realize that design is super important in terms of connecting people with the information and resources that they need, and addressing this unmet need of recent diagnosis and this urgent time of transition. As you mentioned, I also am chair of the design track at HX Refactored. That is a conference that explores the overlap of design, technology, and health. The next one is April 1st in Boston, and it's really going to explore the human component and designing for unmet needs as well as behavior change and exploring that motivational component. So thanks for having me here.
Great. Well, thank you very much. So you certainly have all thrown out some challenges. I want to begin to work on the fixing part. And Alif, I think one of the first things you said is the problem is not having all of us in the same room. And this is exemplary to do this. As I was having coffee this morning, it was nice to see old friends, but it was particularly nice to see new, younger, bright people here that are doing really cool things. I think we're going to hear that in the competition event a little bit later. But how do we get everybody in the room? We have created structures that are almost creating, well, they are creating silos and creating barriers for that interaction. So I'll just open this up to everybody. How do we first do that? What's the structure?
So my bias is that you engineer it in the beginning, because as all of us know, just from growing up, from raising kids, people hang out with people they like, they know, who look like them, who sound like them, who share an interest. So nurses with nurses, physicians with physicians, men with men, women with women, and so on. Cultures and religions segregate themselves by likeness. But what that does is it creates silos of like-mindedness. And when you have like-mindedness, you risk having yes people. And yes people support the same idea because then you fit in. And when that happens, ideas continue along without anyone really questioning them. And it happens in medicine quite a lot, even though we consider ourselves sort of scientists, we publish papers, we do research. But when you go to a doctor meeting, and I've been to many, it's really a bunch of doctors talking to doctors in the same profession of doctors. So cardiologists with cardiologists, emergency physicians with emergency physicians. And you hear it's the same setup, it's the same story, we've all done that. I imagine my colleagues in the other branches of clinical medicine would say similar. But then what we did here was we thought, well, who are we dealing with? We're dealing with people. I'm not calling them patients, they're people. And they're consumers. They pay us for the services that we provide. And more recently with the Affordable Care Act, they're going to feel the economics of their health care, which is something new. And as they do that, they're going to start to introduce consumerism and retail thinking to healthcare because that is their frame of reference. It's not because they're less educated or less likely to understand things. That's how they are in every other mode of life. So that's why it's really important to include folks like Amy and designers and the patients themselves and their families, because one of the challenges with getting them to adhere is to, in fact, break down these silos. And so that's the whole point of today. And I think in the beginning, to your original question, we have to do it purposefully and strategically by forcing the discussion, by putting the people together that need to get together, not those who are already together.
So how do we go about that? I'll ask to each of you. I mean, if you could do one quick fix and just snap your fingers, how would we get people together, break down those silos, and get this ball moving in the right direction?
I think from an organizational perspective, there are shared objectives. So I appreciate the American Heart Association's effort to partner with organizations who are trying to make a difference in heart health because we're stronger together than we are apart. You're seeing employers, insurers, hospitals all wanting to improve heart health, reduce readmission rates. That creates shared objectives where opportunities for collaboration are definitely present. I think a focus on multidisciplinary teams and inviting, to Alif's point, people outside of your realm to the table. If you look at the journey of the person, look through their path through the ecosystem, the consumer is left in the center of a mess. And they are on their own to navigate it all. But if you trace their health journey, if you trace their path through the ecosystem, you will see the organizations they touch and the individuals they touch. And if there's a focus on creating a multidisciplinary team with aspects from everywhere in that health journey, everywhere in the ecosystem, then we're going to have a better effect, I think.
So Robin, let me ask you that. What Amy just said, I think was very interesting, is that the patient is left in the center and untouched. And, you know, I think we would all say we're guilty of that in some of our silos. Perhaps the group that is less guilty would be nurses. They are the ones touching and communicating most of the time. Tell us a little bit about the silos you see in nursing and how we might break out of those.
Well, first of all, I have to commend you for even making that statement and recognizing that. So Mark is a nurse lover for many, many years.
In the good sense.
And don't take it, yes, don't take it any other way. We are good friends, that's it. But I think part of the challenge or the difference with nurses is nurses are taught and trained to look at patients from the holistic perspective. So they're not the sick heart, they're not the bad kidney, they are a patient, and we are trained that people are social, they're sexual, they're emotional, they have all these different layers to them. Hopefully they have many years of happy lives, but they also will die. It's inevitable that we will all be born and we will all die despite our best efforts and research studies, et cetera. So nurses just are acclimated to talking about all those perspectives and reaching out to those patients from those different initiatives. And nurses talk with each other and communicate. And so I don't know John Doe as the guy with an EF of 10%. I know John Doe's phone number probably. I'm a number person. I know his wife, his children, what he likes to do, and I see him as a different perspective, a different entity, and I see his journey. And nurses want to get in and make that journey as comfortable as possible. I think that's one reason why when patients are really, really sick and they know that the end is coming, they'll reach out and first talk to a nurse about that and ask about palliative care and hospice care and how much longer do I have to live, because I think we've approached it to them from day one that this is a journey that we're going to go with them, accompany them on.
You know,
And also, this is my twin.
and next year we're going to make everyone wear exactly the same.
So the women in the audience get
But
that. The
that
men
said,
have no
Robin-
clue what you're talking about.
Robin touches on something, and I think we can illustrate it with a program we have at Blue Cross, but it's in the area of diabetes. We fund an initiative out of Sinai Health System here in Chicago. It's a diabetes initiative. And it came about because Lawndale, which is an area of Chicago, a neighborhood, has some of the highest rates of diabetes in not only the city, but in the country. And what Sinai was doing was essentially taking a developing world concept of training lay people as community health workers and sending folks door to door. And we funded that to a tune of several $1 million. And these folks, they go door to door in Lawndale, and they go into the home, and they talk to the families, and they identify diabetics who've already been diagnosed, but they also identify people who are either at risk for diabetes and are diabetics who just don't know that they're diabetic. And they do this in a way consistent with the culture of the community. So one half of Lawndale is African American, the other is Hispanic. And so the home workers are of the culture of the community. And they've succeeded in taking hemoglobin A1C, so that's the blood test that tells you, for those who are non-clinicians in the room, tells you how your diabetes is being controlled. They've succeeded in getting that to improve by 20% when that community had a rate of about 50% or greater of hemoglobin A1Cs that were out of control. So really uncontrolled diabetes in a community greater than 50% brought down by 20%. By simply getting in the culture and the family and talking to people and educating them and plugging them into the Sinai Diabetes Network so they could start getting treatment. Now that's not technological, it's not fancy, it requires some money, and it begs and borrows from the public health world shamelessly, but it works. So when we talk about breaking silos, we also talk about bringing medicine to a community in a way the community wants you to bring it to them, not in the way that you dictate to them. And that's really important in behavior change, and that pulls from nursing. And I think one of the reasons nurses are so good at what they do, is because historically, women were not allowed to be physicians. So nursing came up as one of the fields that women were allowed to be employed in this country. And as a result, it has a lot of the traits that women are known for, which is that nurturing, that caring, that understanding the human being. Physicians came up a different rank, and I won't go into that. But now that we're integrated, a lot of the beauties of nursing come from that caring piece of it. And I think that piece of, though, however, resonates with patients, and you see it in the Sinai Project as well, even though those care workers are not nurses, but they have that same sort of training.
I have a couple of thoughts on that. I think we can all agree that life and health overlap. And we're so often focused on the clinical stuff that we forget about the life stuff that affects the clinical stuff. And so, Robin, what you said about knowing about the person's family and what they're facing, that's really important. And it factors into the behavior change component as well. So I'm interested in what you think here, David. But there's behaviorism that says stimulus, response, penalty, reward. Get somebody to act initially. Get them to do what we want them to do. And then there's humanism, which says, let's align with the intrinsic motivation that someone has. Why do they want to get better? What matters to them in their life? If we know that, if we understand that, if we consider that, it's not about improving A1C levels, it's about getting onto the beach so that I can be at my daughter's wedding, because right now I can't get there. That's what it's about. When we shift our perspective there, our solutions become more meaningful, they become more valuable. Too often in industry, our focus is on technology. Technology will help, they will support our efforts, but they should not be our focus. Technology's ability to connect people with the meaning, the value, the other humans that they seek will bring us the success that we're looking for. I often like to play with the idea of, what if there were no technology? What would we do? How would we be efficacious? And consider the ideas that come to mind and weave them into the solutions that we're creating.
You know, I do want to add to, Amy, earlier you mentioned about aligned objectives. And I think folks forget, in terms of aligned objectives and looking at the patient holistically, there's also the alignment between all of us. We all have the same objectives when it comes to managing people and the patients. And as I mentioned earlier, having better outcomes. I think we have done a good job in focusing on, let's take a look at this patient holistically and really take everything into consideration. But have we really done a good job in talking to one another and really taking a look at what we all can do together? You know, I listened to David and talked about, you know, just the behavioral change, and it's also something that our group also looks at as well when it comes to what are the challenges in medication adherence for specific diagnoses. So that's a component of that too. And then we take a look at, as we interface with different organizations, you know, we try to find that alignment so that we have that common goal. And at the end of the day, the ultimate accomplishment there is for the patient to really be managed appropriately, right? And there's a lot of gaps, you know, whether it's gaps in care or just getting, you know, folks to understand what the national guidelines are, or, you know, having a focus on medication adherence. A lot of that really can't be done in a silo. It really takes aligned efforts to be able to do that.
And let me add to that real quick. I'm sorry, go ahead.
Oh, just, I mean, I think getting everybody at the same, I mean, I'd take a look at this a little bit more from our research perspective, but also I appreciate what a lot of people have said about needing user engagement, sort of all stakeholders engaged early on. But I mean, you know, all of the projects that we have are multidisciplinary, involving, you know, medicine, behavioral science, engineering, computer science, developers, and it is, you know, everybody agrees about the objectives, but there's a second level of agreement where there is often not very much agreement, and people's incentives don't align. And I think this happens in clinical practice. I mean, your patients, they don't want to have heart failure, but then they have other goals and other incentives that may not align with that. And you know, when we're working with engineers, we may all agree at the top level, but then there's other things that incentivize them. And I think having the team kind of everybody understand what each other's incentives are and be able to take into those account what those incentives are or what their motivations are or why they're in this and try to accommodate it, that ends up driving more engagement. But doing that also risks chaos. Because things can fall apart and nothing gets done because everybody's shifting and you're trying to take care of everybody. So there's also, we've seen there needs to be, a clear leadership structure and somebody who's making decisions and somebody who can say, I'm sorry, we can't do what you need to do. And that balance of, below the top level agreement, that balance between kind of control and ensuring that things are moving forward and taking into account the motivations and incentives of all the different stakeholders. It's, at least in our work, that is a constant kind of operational challenge.
So, but there's a call to action here, and I want to highlight this, being on the payer end. If we collectively do not take this on and fix this in some fashion, it will get fixed for us. We hear constantly from our employers, employer groups, show me the value. Mm-hmm. Show me that this works. Show me that it's cost effective. Show me the numbers that what you're saying matters. And if the medical community in particular doesn't take the reins on what that is, the value will be defined, I suspect, by the business community. Because healthcare is a huge line item for each and every one of them. Mm-hmm. And as you all know, healthcare is paid for by two entities in this country, the federal government and the private payer side. And up until very recently, the private payer side means the employers. And for them, they can calculate for every product that they make how much spend goes to healthcare to construct that plane or that car or whatever their product is. And it's a big line item for them. And it makes it difficult for them to compete. And they have a workforce that they want healthy and at work and working well with them. So when they're managing their healthcare benefit, they're looking at which are the best hospitals, where are the best doctors, who's doing the best work and you can fill in that blank. So I think it behooves everyone in this room to sort out how we can align these incentives and get past that second level, because I think patients are better off if these definitions and these practices come from the clinicians and the clinical community, because we know what medicine is about. But if we are unable to do it, they're going to come. It's just a matter of time.
But I also think in this equation, and I agree with everything you said, especially your jacket that you're wearing.
He likes my jacket.
I think we can't take the patient out of the equation. They can't be a victim of the decisions that we make. They have to be an active participant. So we talk about patient-centered care, but how many of us really involve the patient in the decisions? Do you want an LVAD or not? Do you want to take this medicine? What are your goals for care? Do you want to live 50 more years? Well, that's not likely to happen, but do you want to make it to your child's wedding? That might be doable. So, I agree with everything, but I don't think that we can walk away from it that far and not involve the patient and include them and their family in this whole discussion.
Yeah, it makes me want to say some really happy, crazy stuff, which is, Alif said, they're not patients, they're people. I mean, I think we like to, when we conduct research with people, with patients, they're tired of being sick. They're tired of being known as a patient. They're a person, right? So I think we want to avoid them becoming patients, but unfortunately, this is an industry where we treat the sick, and like you said, we're paid for it. We want to treat them the best way we can. We want to help them achieve wellness. We want to cure them if we can, help them live better lives, quality of life, all of that. But prevention isn't monetizable. I think that, at least so far as I've seen, I'm looking forward to y'all figuring it out. But I think that's our biggest challenge, is in prevention. How can we do evidence building around prevention such that people will pay for it? I think that's the biggest challenge, and maybe everybody's minds just exploded, but I think it's super important.
So there's so many things to follow up on here, but I do see some hands, and so I'd like to hear your questions. Yes, please.
This is Karen I'm from DePaul School of Nursing, and lots of great information. I'm glad that Alif brought up the point about the financial side of things. One of the great things about, for example, focusing on the Champion study was that in that sort of artificial environment of a clinical trial, you had to have nurses that were, whether they were APNs or RNs, that were looking at those numbers. Now, granted, they were working collaboratively with the physician, but let's face it, it was probably mostly nurses that were looking at those hemodynamics and interacting with the team in order to make clinical decisions. As far as what happens, to David's point, the coaching that then occurs, whether it's medication adjustment or sodium adjustment or just asking about how do you feel, that occurs, again, with that human interaction, which I think is really important. And so it's that connection between the data, that whatever kind of data we're getting with biosensing, and how do we connect that with the coaching. So if we know it works well in a clinical trial, and we know there's plenty of evidence that coaching works, how do we then turn to the reimbursement factor where not just academic settings can afford to have APNs and RNs on a team of heart failure management, but we know most heart failure is managed by primary care providers. And they don't have 3 or 4 or sometimes even 1 nurse that can deal with managing numbers like that. So in your opinion, like, what is the direction of having this human interface between the data that we get from any kind of biosensing?
Who's going to take that on?
Well, I mean, I can get us started just from, and this is, again, it's not in heart failure, but it may be analogous, so there may be some analogies here. So there was an application that was developed to and evaluated, and the aim of it was to try to promote, to keep, for people with substance abuse, once they're released from inpatient clinics, to keep them out. So, common problem. It had a number of features, and it was supposed to connect people, or it does connect people to a provider, and that provider can kind of manage the flow of information. It has a lot of cool stuff, and it has a lot of geosensing, so it can kind of, when it detects that somebody, if they're an alcoholic, that they're close to an establishment that sells alcohol, it can try to veer them away, and it's a nice app. There's social features. But, after the publication came out in JAMA, big publication, Dave Gustafson, who developed it, has been trying to push it out to community mental health centers. And he's got a group, and Kaiser Permanente, they've got now kind of a large group where they're deploying it. And so we met with people from those clinics about how that was going a few months ago. And by and large, the ones where so most of the clinics were taking the approach of trying to hammer the clinicians to get them to start using it. And that invariably failed because, clinicians, it just didn't fit into their workflow. They weren't going to change. And the clinics where it's been successful and highly successful have been those where they gave up trying to change the frontline clinicians and put what essentially are care managers in charge of the process of overseeing that. So I think kind of in practice, and I suspect that this is true, it's hard, especially in primary care. I mean, people are just, boom, 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 one thing after another. They're so busy, it's really hard to get change in there. And so I think, we have to find ways like using care managers of inserting these tools, at least for now.
And so to build on that, that's sort of the premise of value-based care, where intensive medical home programs, which we have at Blue Cross, or accountable care organizations, is essentially set up where they're supported financially up front, but those organizations within their own culture have to come up with a way to do things better, to do quality work, determine the value, bring down the cost, and have better outcomes for their patients. And then at the end of the time period, they retain a financial piece of that equation. But we're not in there telling them what to do, because their culture is their culture, and they're going to need to figure out how best to make something work. So if the idea is to manage my diabetics better or manage my heart failure patients better, then the folks in that institution are charged with getting together, talking to their different counterparts across their enterprise, talking to their community, and coming up with a solution that works for them. And this is the point with your data point is a lot of the data solutions out there where you're collecting volumes and volumes of blood pressure readings and heart readings and all kinds of things. Very few of them actually have thought about, at least that I've seen, how is that going to work? Who are we going to feed that to? And when we feed that to somebody, who's going to look at it? None of the physicians I know are trained, or nurses I suspect as well, in their education or in their residencies as to how to manage something like that. I'm not sure that the hospital systems or any other system actually has the ability to take in that data and put some intelligence around it and simplify it so that that very, very busy clinician doesn't have yet one more thing to do. And you have an office practice that may be a little bit more sedate, but you go into the emergency department where I don't know what's coming in the door at any given hour, and I could go from having a completely, dare I say the quiet word, quiet institution to people packed in the hallways. I'm not going to have time. So it's that human experience that Amy has so well articulated that not only has to apply to the patients or the person seeking healthcare, but the practitioners too.
Yeah, I'm like jumping out of my seat here. So there's actually a practice dedicated to this, and it's or a discipline rather, and it's called service design. Mayo Clinic, Kaiser, they have service design teams, and what they do is they observe what's going on in the clinical environment, what is the workflow, and where are opportunities to change that. So the consumer experience, the customer experience, the patient experience is a byproduct of how the organization is set up internally to support it, through technology, through workflow, through people. At my firm, we actually have a deep focus in behavior change, and we're looking at leveraging motivational psychology to help people change their behaviors, but also to help organizations change their behaviors, because it's really tough to change. And you can create this great technology, but if nobody's using it, it's not going to work. So really figuring out how do we get organizations to change and adopt new workflows, and that happens through observation, through understanding what people are struggling with, what are the obstacles, envisioning a better process with them, and then testing it out to make sure it's working.
I'll make one. Go ahead. I'll make one comment. I think changing workflow is so important, but if it's just one group making the change and it's not integrating with the rest of the group. That's the problem with the Sinai project, is that they're trying to fit a novel, innovative approach into a staid and unchanging culture. And so, but let's get a few more questions from the audience. Please.
Good morning, Clyde Yancey,
Hi, Clyde.
Northwestern here in Chicago. I want to compliment the organizers, you especially, Mark, for leading this discussion, because I think this is very important in trying to bring together the themes here. I have a question for the panel. This is the Innovation Forum, and we've identified heart failure as the disease du jour, which I completely support, those of you who know me professionally. I am of the mindset that Amy's presence is uniquely important in this conversation, because as a clinician scientist, several years ago, I would have very quickly dismissed the notion of a patient experience officer. And having spent 4 years now working as a member of the Patient-Centered Outcomes Research Institute and really listening to patients and understanding their input and their experiences better, I realized that this, Mark, I think, is the hurdle, the number one hurdle that is different than anything else we can consider by getting our patients more engaged. But here's the question. So within the American Heart Association, we just recently published one of our journals about the PROSPER study, which took stroke patients and captured their experiences and placed it in the medical literature, and it was editorialized by several of our peers and colleagues. And now within the heart failure space, the American Heart Association has set up a citizen scientist group, which is a panel of patients who are very articulate and are able to, again, craft out, design, and speak to their experience. The point is this: we have a number of nascent activities done by pharma, by insurance companies, by nursing organizations, by mobile health technologies, by startup initiatives, but we don't have the aggregated big effort. And I think if we identify that the patient experience is really the hurdle, that is really the hurdle, no matter what the endpoint is, whether it's palliative care, readmissions, whether it's improved outcomes. The patient experience is what needs to improve. What's the big idea? How do we come up with something other than a series of small operations, but get the big aggregated effort to really test what it is we can do in a very reasonable, cost-effective way that would improve the patient experience and then improve outcomes? It may take everybody on the stage plus in the audience, but we should give some thought to what is that way to bring it all together.
Please.
So my personal opinion on that is twofold. One, we just need to stop being silos. If you're a big academic medical center and you're another big academic medical center, start talking to one another. Start talking to your safety net hospitals in your neighborhoods. Drop those walls. It's that simple. Second, in Chicago in particular, we're lucky here. We have accelerators here. We have one called Matter. It's opening in January or in February, in that range. And that is a place where different groups of people are going to be able to come together and solution around healthcare issues, the major issues. If we can drop the silos, if we can stop competing for just a bit and realize that in the end we're all going to do well and start talking to one another, I think that would help. And I think organizations like the Heart Association are uniquely positioned to be able to do that or to facilitate that, because all of us who are working with heart disease are affiliated with you in some fashion.
And I think to build on what Alif said, in terms of working together and dropping the silos, I think it's time for us to take a look at our capabilities and resources that we can share with one another. Looking at that common goal and saying, okay, these are the things that are aligned with what you're looking at, and these are the things that we can bring to the table. One thing I did want to mention earlier too is that, you can't really manage what you can't measure, and that's been true since I started my career in the medical field years and years ago. But yet, now we have what we think is a sophisticated way of getting all the data and the big data, but what do we do with it, right? And then when we identify that, like to Robin's point earlier when we were talking off stage, then who's going to do it? And that's only going to happen if we all sit down and understand what we can all do together and what we bring to the table.
Yeah, it's a great question. Just one quick thought on it. There are innovation centers within insurance companies, within hospitals, within large technology companies in the healthcare space. There are programs developing now that connect those innovation centers, and that'll happen more and more. Hospitals are turning into technology companies because they're tasked with caring for individuals outside of the walls of the hospital, before the visit, after the visit, and ongoing in terms of condition management. So the more that hospitals can learn from companies that have already figured this out in the tech space, the better. There's also collaboration happening within innovation centers cross-industry. So you're seeing Kaiser, JetBlue, and some automotive company saying, okay, how do you approach innovation? How can we learn from each other? So it's not just in healthcare, it's going outside of healthcare too, because some people have figured out some of this stuff already.
Can I give a quick example? The UNICEF is working with a company called Frog Design, a design firm out of New York, to tackle HIV in Africa, in South Africa, amongst males through text messaging. UNICEF, a design firm, clinicians on the ground in South Africa, and South Africans. Those disparate, if you think on the surface, connections have fostered the ability to get young men who culturally would not show up in a clinic to get HIV testing, simply because the text message shows up and says, you need to get tested. They send them a home kit, they test in their house, they mail it in, they get their results via phone, and then they're triaged. It's those connections that don't seem obvious that seem to move the needle.
So let me try to get one or two more questions in. David, did you have a comment?
I was just going to mention, I think, more on the sort of the development of tools for, I think the question was about, needing to have patients involved, and I think we've all kind of spoken to that. But I think, that we're, patients generally agree with their docs that they don't want to have the disease that they're being treated for. But again, they have specific needs, they have specific motivations and incentives, desires that may be able to either interfere or support those clinical aims. And so, at least in in the work we do, we often do a lot of what's called user-centered design, where we try to understand what those needs are and then begin to design tools that work around them. So, for example, trying to get medication adherence, most people want to get better, but unfortunately, a lot of people don't connect the idea of getting better with taking their medications, regularly. But one of the things we found is that people do like their nurses, they do like their doctors, and so again, letting them know that we're providing that information to the physicians has been one leverage point that's increased adherence. But they had some concerns about how those data might be represented or given, and so they didn't want individual days. The idea that you missed a day here, that was uncomfortable to people, but sort of generic percentages over a month were okay. So beginning to understand kind of what your leverage points are, what their interests are, what the interests of the patients are, how those interests can potentially be aligned with the sort of medical goals I can help us develop smarter and more effective, more usable and more used tools.
Great. Let's get in a couple more questions if we can. We have 0 minutes left. We have 2 minutes. One last question. Dr. Casey.
Thank you very much. Don Casey, member of the executive leadership team. Thanks to Mark and the panel. I'm a physician and also one of the co-authors of the most recently published heart failure guidelines led by Dr. Yancey. And Dr. Silver was involved with this too. So I want to, before I ask my question, put in a pitch to the audience to be sure you take advantage of, for free, getting the new guidelines from the American Heart Association to understand the complexity of heart failure. And for those of you that aren't familiar with it, it's really worth it. So the Heart Association invests a lot of time and effort into these guidelines, which provide the foundation for treating diseases like heart failure. I also want to publicly disclose that I'm wearing my American Association of Heart Failure Nurses pin that I think Dr. Trupp gave me.
Maybe.
And so my question is, Dr. Trupp, we have programs like the one I worked on in New Jersey called Heart Success, where time to hospitalization for heart failure patients is measured in months and years, not this artificial 30-day readmission thing. And I know when patients come in to see you, the likelihood that they're going to ever go back to the hospital goes way down. So if you had one thing to say relative to Clyde's big idea, and perhaps maybe reflecting on Nancy's point about nursing, what could it be in terms of how we might start in Chicago tomorrow, lowering the numbers that Mark said haven't changed in 10 years?
Oh, I'm glad that was such an easy question, Don. I'll be taking that pin back in just a few moments. I don't know that I have anything that innovative, because to me it seems pretty basic. We just have to get these individuals together and look at a concerted effort, what we can accomplish. And I think Amy said it earlier, or alluded to it. Aristotle said years ago that the whole is greater than the sum of its parts. So if all of the energy, or even half of the energy and interest in this room, were able to be harnessed together, we could accomplish a lot. I think breaking down the barriers and the walls, and maybe just forming a consortium of individuals that are interested in this, not just at academic centers, because as someone in the audience said earlier, most of these patients aren't managed by academicians or people even in large practices. It's the primary care providers out there, and many times they're not involved when we get our groups together. We totally forget about them, or think that somehow they'll get it through osmosis. So I think we just have to really sit back and restructure and rethink and throw away the thought that we've always done it this way. We need to create a brave new world for tomorrow.
So we have to close on that note, the brave new world. I want to remind everyone a couple things. One is that during lunch, and there's a networking session later today, this is a small, cozy group. I encourage you to talk to each other. And Clyde, I want to thank you for the comments about American Heart. My observations over the years that American Heart has gotten to be a bigger and bigger organization, but rightfully, they touched all of the partners. They've touched certainly the patients, the scientists, but the payers and industry. And I am really giving kudos to being one of the premier organizations to pull it all together, and this is all being done under the auspices of the heart. The last thing I'll ask you is that as you walk out of here today, you must think of a way that you're going to change in your own life. Don't go to one of your typical society or industry meetings. Go to something that's completely out of the box. Begin to have discussions. Otherwise, we won't carry this forward. There is a huge change we have to create. It is almost overwhelming, but I do believe that with the guidance of this panel and all of you, we can do it. So thank you very much.
Thanks, Dr. Silver, and thanks to our panelists. Thank you very much. Awesome.